Okay, well, I'll just start again. I was saying, as CASA advocates and workers, we work with families, and on a regular basis, we have in court, we hear of our families having FPP placed in the home. So we're all familiar with that, but we're not real familiar with the process or understand exactly what that means. Can you kind of give us an idea of what that means when the court orders FPP placed in a home?
Well, our referrals that we get, some are court ordered and some aren't. Most of them aren't court ordered, so to speak. They may be court active, but we can also get referrals that aren't court active as well. Um, we are a voluntary program on our end, so we can't tell anyone they have to do our program, but a judge can court order it, or social services can strongly recommend it, encourage it, and sometimes even tell them if they do not participate in our program that then they may have to petition, go before the judge for removal of the children. But it's definitely voluntary on our end.
Sorry, Vicki, I'm in transport. I'm moving from one office to another.
Oh, okay.
Because again, it was like, and this chair is like raising me clear out of my view, I'm sure.
Can I ask a question?
I've never had so much trouble with one of these, but man, let me see if I can come back on here and you can see me. Let's try this again.
Vicki, is there like a summary or synopsis of the FPP program that we can look at?
Yes, I have something. Susan has it, but I don't know if she's able to share it. But I sent it to Susan, and I think Robin has it too. So maybe she can even share that with you guys after. But I can go over it.
Yeah, we can send that out to everyone that's included on the Zoom today afterwards, if you guys want.
As far as just me verbally sharing it with you, we provide family counseling and intensive in-home services to clients and offer in-home interventions. And it's all in an effort to maintain the safety of the children in the home. We're there to preserve the family if at all possible. Probably one of the most misconceptions about family preservation program is that that's our only goal, is to preserve the family, and that we don't ever recommend that children be removed. And that's not the case at all. If we go in and we assess high-risk situations in the home and we feel like the children are not safe, and if we can assure, and when I say assure, that's kind of a strong word to use, because obviously we're not there 24/7. We can't know everything or see everything that's going on with the family. But if our specialists, that's what they're called, family specialists that work with these families, if they feel like the children are to the point unsafe, then we don't stay in that home and work with them. Now there may be high risk factors that to a lot of people you'd say, well, it is unsafe because there's high risk factors. But I mean to the point that their safety is at risk, then we would tell DCBS, social services, that this is a case that they may need to go ahead and look at removal. That's their call to make. It's not ours. We can make the recommendation of that, but it's not our call to make. Then that's up to DCBS. So while we're in there, we need to have some security and feel like that we can help to maintain safety while we're in there. So our specialists work on lots of different things. It depends on, one, what DCBS would like us to work with the family on, but we're also very family person centered, where we feel like the families are experts of their family more than anyone else. They know their family, they know their obstacles. And we also want them to participate. A lot of times families in the court systems are told what to do. Not that that's not important, that is important sometimes, especially when children are at risk, but we want to be a partnership with the family. So we have them set a family goal, an individual goal, and they name their plans. We make it very personal for them and help them come to the point where they see that they need change. And we feel like if we partner with them more than dictate to them what the change is, then that makes them more apt to participate and work harder to make those changes. our specialists work on lots of different things. It could be parenting skills, stress management, time management, budgeting, helping them with substance abuse, domestic violence, where they're not substance abuse counselors, they're not therapists. We refer out for that. And typically, if we get a case that there's a DV history, active domestic violence, or substance abuse, really what should happen doesn't always happen, but in the best of the worlds, what should happen is they should already be involved in counseling when we have the case. We are just there to help supplement whatever programs they're already involved with and kind of have a pulse on the situation and what's going on. When we say we're intensive services, we're in the homes probably 2 or 3 days a week, depending on what program they're in. The IFPS program is Intensive Family Services Program. They are working with those families anywhere from 6 to 10 hours a week. They cannot go longer than 2 days without seeing their families. So that means they see them on a Friday, they see them on a Monday because you have the weekend. We've had specialists work on holidays. I mean, so they are in close contact with those families. That program, the more intensive program, only lasts for 4 weeks. 4 weeks is not a lot of time to make change, but it gives us a lot of time and the extra hours they're in there to assess the situation, to see what the high risk factors are, report that back to DCPS, the courts, and hopefully have a plan for what the family needs down the road. That program, they're putting fires out a lot. They hit the ground running with the family, and there's usually, typically in those kind of cases, they're putting out a lot of fires and getting a lot of things in place, supports for this family. Our 3-month programs, which is FACTS, which stands for Families and Children Together Safely. FRS stands for Family Reunification Services. And then we have a diversion program. That can get complicated. They're pretty much the same. There's a few little differences in the programs, but for your purposes, what you would probably want to need to know the best on that is that they are 3-month programs, less intensive hours. They're 3 to 5 hours a week, and they try to see them every 3 days. So they're in there a couple times a week, and it's longer services. So they're working with those families a minimum of 3 months. Our program, the FEP program across the state, has went through a lot of changes under the Family First initiatives. I don't know if you guys are familiar with that, but we've been able to, now we can extend the case several months out past the 3 months. It almost feels more like a case management program to us than intensive program, what we're used to. But I think what programs and legislatures and people in this field are realizing that people don't make change as easily in a month or 3 months. It takes longer, especially when we're dealing with sobriety. Realizing that these families may need those supports in place longer. So now this is new to us in this past year, but we are able to stay in there even longer with the 3-month programs.
Gotcha. That's awesome. That was actually one of my questions. I had the IFPS and the FRS and the FACTS program and diversion, and was going to ask you to explain the differences in those. Would you say, so that the intensive family preservation program, and is that primarily if the children have not been removed, right? That's trying to go in prior to that happening, and then say the family reunification is the one you would utilize if they've already been removed and are going back. Is that correct?
Sometimes, Susan, I mean, we have got IFPS cases before where they have been removed, like a history of that maybe. They've been removed before, but been back at the home for a year or so. But typically, it's going to be a case where they're at imminent risk for removal. So we are now under, and I'm trying not to make this too complicated, but we are now under a new model, a home builders model, which FEP's kind of been based on the home builders model for years, but it's changed somewhat. But and we're now have staff and a team getting certified in that. But under the home builders model, they pretty much say, in order for IFPS to take a referral from DCBS, it has to be so imminent that if we ask DCBS the question, we don't have an opening right now. What would you do with these kids if FPP is not going to be in there? DCBS would have to say we would remove. So it has to be that imminent for us to now take them under the 1 month program. It wasn't that way in the past. So we're going to see probably less referrals go into IPS because it has to be like these kids are this close to being removed and you're the last ditch effort or they'll petition the court to remove them. So we'll probably see, we're already seeing that, but everybody's getting used to the changes, even DCBS, but we're already seeing less referrals coming in to the Home Builders IFPS model and more to our 3 month programs. But reunification, yes, it's typically the children are returning to the home, but our FACS program also has what we call a FACS preservation program and FACS reunification. So we can actually take reunification cases under FACS too. And diversion. So all 3 of those programs have a reunification component, which just really makes it better and more open for us to take more of those cases.
Okay, I appreciate it. And again, I'm sorry, I had a little bit of issues there in the beginning of this Zoom, as you know. So you may have answered this while I literally took my computer and moved from one office to another. So while you were talking, so I didn't hear everything you said in the early part. I heard that question, but you may have already answered. I'm going to ask again if you have. Your referrals for FPP, do they only come from DCBS or the courts?
They only come from DCBS, yes. Our contract is with DCBS only, and that's FPP programs across the state. That's the only referral source that we have. Now, the courts, and I've often got a text from our family court judge, Gordon, while she's on the bench. And she'll text me and say, I want this family to have FPP services. And I can't even tell a judge, I want to, but I can't even tell a judge, okay, send it on. I have to say, well, it has to go through DCBS. But typically that'll work well. She gets, you guys know, Judge Gordon, she gets on that phone and she makes the calls and makes it happen. So, as long as we have an opening, we do our best to take those cases. But we just don't know. Say if we have 5 openings and DCBS has cases that they know they're at imminent risk for removal or need to get those services in there, you know, they have their list and their priority of what they're going to refer to us. So, you know, we can't cross that boundary. We want them to be able to have control of that, of what they send us as far as the risk factors involved and who needs those services sooner.
Right, gotcha. Okay, once you get the referral, and again, you may have answered this, but I'm playing catch up here. Once you get that referral, how do you assess, how do you determine how intensive these services are? Do you have a specialist go to the home and they just by talking to them determine? Is it what DCBS seems to think is necessary? What's your assessment process?
Well, it's a lot of things. When we get the referral, the more intensive program, they have 24 hours to make contact face-to-face with that family because we feel like it's serious enough that someone needs to be laying eyes on that family and those children and assessing quickly what's going on. The 3 month programs have 72 hours to make that face-to-face contact. One thing they're going to look at, obviously, is the referral history from DCBS, the prevention plan that DCBS has in place. They're going to look at those things. They also do an assessment tool. It's called the NCFAS assessment, which stands for North Carolina Assessment Tool. This tool was pretty much, it's a tool that social services uses. And when they created the tool, they had FPP programs in mind as well. And there's several categories they assess in that tool. I hope I can do them off the top of my head. It's environment, and there's several things that go under that. It's parenting capabilities, it's family interactions, it's family safety, child well-being, caregiver ambivalence, like what's the caregiver if it's not a parent, grandparent, aunt, whoever, what, you know, how do they feel about the children being in their home? How do they feel about being the guardian of these children? So it's a pretty thorough tool that they use, and they score in the beginning of intervention, they score the risk factors. Then they have an intermediate time they score, 2 weeks into the 4-week intervention, and a month into the 3-week intervention. Then when we close the case, that assessment tool is scored again. DCBS gets all of those assessment tools. We even have to get those to them within a certain amount of time once we do them. That's under our contract, and we have a monitor that checks that yearly to make sure that when that tool's done, it's sent to DCBS in the contracted time. And then it's just continue. It's by observations of the specialist. It's by the client self-reporting. It could be talking to community partners and seeing, what they're seeing that's going on with this family. So it's a continued assessment. We just don't do that one tool and that's it. They're also required under contract, another contract requirement is to update their social worker, the social worker on the case. The intensive program, they do weekly updates on their cases. And then the less intensive programs, the 3-month programs, bi-weekly. And those updates, it's pretty much just saying what they're seeing in the home, any concerns they have, any progress the client's making. If they need more information from the worker, they're saying, or, just brainstorming with the worker on other support systems to maybe get in place for the family. And then we also have treatment team meetings. And I know CASA's been involved in some of our treatment team meetings. We always welcome you guys in treatment team meetings. Let me say this, and this will probably be a question, I'm guessing, but when I say we welcome any collaboration with CASA, because I think more collaboration with these families are better in any situation, but we are tied to, on our end, the client has to agree to that, and they have to sign off on it. It's kind of strict requirement on our end. So we have we can share with the DCBS worker. We have to. We're contracted with them. But if the client said, I don't want you talking to my CASA worker, we can't. And that
if I can jump in on that real quick, Vicki, how can we as CASA, if we want to be included, how can we request that the special, if we're not even, honestly, I wouldn't know when the specialist is going to go see a family of mine. So how can I reach out to, and quite frankly, a lot of times, I'm sure you're aware, when we get told that FPP has been placed in the home, we don't really know initially who the specialist is that's going to the home or who we need to reach out to. How can we become more educated in how to collaborate with your program? That's
a good question. I would say the best case scenario would be talking to the worker and saying to the worker, I would love to collaborate with the FPP specialist, maybe even do some home visits together. Get the worker on board, because the worker can have more pull with that client than any of us, okay? Because they're more in that authoritative role where they could say, listen, I want you to be on board with all these service providers, because we can't make them sign off on that and say that we can talk to you guys. We just can't. Our specialists can talk to the client, and we've had specialists to encourage that with the client to say, we're all here for your benefit. We're here to work together. If you're comfortable with it, I would love to be able to collaborate with your CASA advocate. They can come to the treatment team meetings. When we have a treatment team meeting, that's something the specialists encourage the clients, is to invite people to those meetings, whether it's Aunt Sue, your CASA worker, your school counselor, therapist, whatever. We want that. We want to see more providers present for those meetings because it's just more productive for the whole family.
Right.
So those are two avenues. You talking to the client, your client yourself, and the social worker. You could call if someone gave you the number. We couldn't call you and talk to you about the case. You could call us and let us know that you're in there and involved. Usually when our specialists know CASAs are in there, and sometimes they find out by accident too, they'll bring it up and say, well, my CASA's coming tomorrow. And they're like, oh, you have a CASA? You have a CASA advocate? So usually when that happens, they will try to get the client to open that up to where we can collaborate together.
Great. That's good.
But as we know, a lot of people in the system, and I understand that and get that, they're suspicious of service providers. They're not trusting. They're not comfortable people being in their homes, and the more of us makes them even more uncomfortable. So sometimes, obviously we get resistance because of those reasons, but.
Right. Gotcha. Speaking of that, how, because I know part of FPP is you go into the homes and you work directly with these families in their homes. How's COVID affected you in that way? Are you guys able to do in-home visits now, or
COVID's affected
on?
us. It's affected us tremendously.
Right.
It's very discouraging to us, but we are not able to go into the homes yet. We're having to follow suit of what the governor's guidelines are and the cabinet, since we're contracted with the cabinet. What we have been doing is we've been doing porch visits, driveway visits, yard visits, where we feel like we can still say we're social distancing, we're wearing our masks, gloves, whatever we need to wear. We have had 2 cases where I had to get special approval for a specialist to go into the home, and still trying our very best to do social distancing in the home. That particular case, we were trying to meet a family of 5 small children out in the yard, and no one could control the children from getting close to a street, and it wasn't safe. So we don't want to make it unsafe for us to do visits. And this was a parent that said, I need your help terribly. The parent was, begging for help. So we were like, we got to get in that home and try to help them.
Right.
But I will tell you, from the state down to even our CEO, they're not real comfortable us being in the homes yet. And it's really more to protect the families, because, they're going from client to client and traveling to different, they cover 7 counties. And so we don't want to expose a family or any children either. So
Right.
our staff are ready. They're frustrated. They're ready to be back in the home, and they're getting very creative. So when COVID first hit, we were pretty much limited to video calls, and that's if the client's phone had the capability to do that. And we would ask to see the children on those calls. If there were environmental issues in the home, we would ask them to take the phone around, let the specialist see the rooms, talk to the children. But to be perfectly honest, obviously it's not the same services we're used to.
Yeah, I think that's true for everyone right now.
Now you guys are in the home, right? I think I've heard that.
I'm sorry?
True? You guys are going back in the homes, is that correct?
No,
oh, someone told us you were. I was wondering about that.
No, we had a short period there where things started looking like they were going to lighten up, and we thought we were going to be able to, but we're back to not having visits now. So no, we're under the same guidelines as you are, sadly. We'd like to go back in the homes, but we can't, and I understand that. And quite frankly, as the court liaison, I can assure you the judge holds these families accountable for exposing. So if they're trying to keep their children in their home, but they're exposing them, that's been brought up more than once as actually being held against the family. So we don't want to do anything that would be detrimental to those families either. So I feel your pain on that one. We did have a question. Would you say that this provides an extra component of accountability to have FPP in? I can answer that, yes. Absolutely it does. But I'll let you expand if you want to, Vikki.
You mean just in general, not during COVID? You mean just FPP being in the home, extra accountability for that family?
Yes.
Well, most definitely. I'm not trying to brag, but I guess I kind of am. But I think we're one of the most intensive programs out there. And we are unique in our program, which I think makes it beneficial in working with clients. In time, typically, not always, but typically the families we work with, we establish a good rapport with them, and they probably share with us more than they do most people. And I think that you're in their home environment that much, that just naturally evolves and happens. And we also, that's why we like to try to have that partnership approach with our families more than an authoritative or, dictating approach, because when it's a partnership, they tend to cooperate more and open up more. And I don't say that in a manipulative way. I hope that doesn't come out that way, but it's just, you have someone in your home 3 days a week, and they see your ups and downs, and it's beneficial to us to see clients in their own environment and how they interact with their children, what their daily routines look like, the obstacles, maybe if they don't have transportation, or their plumbing doesn't work, or whatever's going on in their home, and more than if you just see someone like in an office setting. So I think that's what makes family preservation a unique program as well. So
Let me ask you this: have you had? I'm sure you have. And how do you handle it if you have a family that has had FPP either ordered through DCBS or the courts or whatever, and the families are reluctant to allow you into their homes? How do you guys handle that? What do you do about that?
We have a strict compliance policy on our end. So if a family, we have to make those weekly visits. If we're not making them, we're not adhering to our contract. We could be cited for that on our monitoring visits. So we take it very seriously. But then they're a non-compliance. We kind of do this thing. It's kind of within our program, but we'll kind of say like 3 strikes you're out. So we'll give them a couple chances, and we'll be like, if they missed an appointment or they forgot, okay, and our specialists tell them that, if this continues, you're non-compliant, we have to close the case. Again, we have to close it because if we're not seeing those families and we're not laying eyes on those kids, we can't assure their safety. And so if we can't assure their safety, we're supposed to close the case. Now, sometimes, not talking bad about DCBS, but sometimes DCBS was like, oh, well, you don't need to close the case. It's even more serious if you close. We don't know what's going on with that family, but I feel like that helps keep the family more accountable, because typically if that happens, most of the time, not always, but the social worker will be like, okay, you didn't comply with FPP, so we're going to get this back before a judge or look at removal. Doesn't always happen that way. But sometimes it does. But we're pretty strict on that. We have to be able to see those families, and we won't put up with that very long. If we're not, we have to close the case.
Good. Okay. We have a question. How is FPP different from hands?
Well, hands is going to work more on parenting issues, and I think the age of the children too that they work with. It's younger children, so we're working with 0 to 18. And we're going to address issues across the board, not just parenting issues. Parenting is a big part of it. And also, I hope I'm not saying this incorrectly, but hands also, they cannot take cases that are more of imminent risk as ours, the higher risk cases. They can when the risk factors get lower. And I hope I'm not confusing hands with Building Stronger Families. I know Building Stronger Families is that way, but I was thinking hands was too, but I could be, I'm not sure on that, you guys. But so that's a difference. And I would say we're probably more intensive. And hands is a wonderful program. And we're in there a lot when hands is in there too. But like I said, we're seeing clients probably 2 or 3 times a week too. So it's a more intensive program.
And I do know the age on the hands is like 5 and under. So it's
under, yeah.
Right.
Mm-hmm.
So I understand that.
And we work with a lot of teens. I mean, our diversion program probably takes more cases working with teens, and that's where we will even set individual goals with teens. So like if teens are becoming status offenders or just, having a lot of problems in school or different things like that. So a lot of times we'll have a family go, and we can have an individual go with the parent and also an individual go with the teen. So right. I don't know if they can transport. We can transport. We transport often. Our specialists help clean houses, you guys. They help them set up a budget. They do laminated chore charts with them. They transport them to doctor's appointments. They get them set up for grits because we want them to have transportation when we're out of the home. They help them apply for SNAP benefits. We've had some, they'll help them apply for financial aid because they want to go back to college, or, anything they can do to be a support. They really try to take advantage of that time they're working with the family and in the home to do that.
That's awesome. That's awesome to know, because we do, as you're aware, work with lots of families that need a lot of those services that we aren't capable of assisting. I mean, we can't transport them to those places. Mm-hmm. So that's really good to know. Thank you, Vicki. I was going to ask you, as far as you talked about grits, and I'm trying to stay on FPP with you, but obviously Audubon, I used to work for Audubon, so I'm very well aware that Audubon's umbrella encompasses so many different things. It's just mind blowing. And I did kind of jot down a few things just because I wanted to make sure our advocates are aware of what these things are and all the services. One is the Connect program, which is still, and I don't know if I can just basically I want everybody to know that Audubon does Connect, which is the health benefit assisters. It started under the Affordable Care Act, but they literally have assisters still there, even though we have a new, president, and that's changed, but there are still assisters, and I'll let you tell them a little bit about
and it was called Connect in the past. The name has changed. They're the health benefit assisters now. They're actually in the building right down the hall from where we're at, FEP's at. There was a rumor that when the new governor, the new administration came in, that was going to be done away with, the previous one actually, but the new one did keep, the new governor, Bashir, kept the program. Under our previous governor, he did not do away with it. We heard he was, but he did change the name of it. So I think a few things changed with it, but what their main goal is to assist people in finding affordable insurance, and they can go through lots of different insurance programs to do that.
And I just wanted to bring that up because I know we work with lots of families that are low income and need that extra assistance. And I don't know if any of you have ever gotten on that healthcare.gov site and tried to navigate your way through it, but it is a little complicated, especially for some of our families. I can't imagine.
It is complicated. Yes, it is. And usually our specialists will refer them to an assister to do that because obviously they're versed in it and better. We've had specialists help do it before, but I try to get them to, one, that's their job, and that program focuses mainly on that, and they're going to be even better at it than our specialists. So, but yeah, and we do a lot of, they're required on each case to do so many referrals with the family. And if they say, well, I didn't really see any referrals need to be made, well, there's something you can refer. So we, those are the kind of things we're going to refer families to. LIHEAP assistance, which is also through Audubon. Are you guys familiar with LIHEAP?
It was on my paper to ask you to tell them about it, so go right ahead.
Okay. LIHEAP stands for Low Income Home Energy Assistance Program. They're also housed in the same building. I used to do that job years ago. And they help families with their utility bills. And the weatherization program collaborates with them too. So a lot of times if they see their utility bills are running really high, they may see if they need which is another Audubon area program, weatherization, to get in there and help them, with insulation or, putting, the plastic on their windows, or just, sometimes they can even change out a heating unit or air conditioning unit. So those are some things that they do. And they'll sometimes have money available. And there's also under the We Care Act now that's come out through COVID, they'll have money available to help with rent and different things like that. LIHEAP actually has been running programs back to back. They, like a lot of programs, have got additional money because of COVID, and we're running a summer program right now. So to help, so you can let your families know that as well. They are not.
Because those utility bills in the summer are sometimes worse than the gas bill. So that's good to know.
Oh, I know. Yeah. It's a little different now because they can't have people in the building either. So they have a drop-off box at the location on 4th Street across from Lee Manor Apartments. That's where the office is at. And people can leave their information there, and then they process it, and then they can come back and get their information. So they're not allowed to come in and do it like they have in the past, but they are still running full operation and helping people with utility bills.
One other program, you touched on it earlier, but the GRITS program, that's your GRITS buses. For those of you who don't know, Audubon also, that's under the Audubon umbrella. And what are the criteria for someone using a GRITS bus?
Okay, I hope I can
just briefly. I know it's not your
Actually, anybody, if I understand this correctly, anybody can use the services, but if you're not a low income Medicaid, Medicare recipient, you would pay a different rate. So, but say if you didn't have transportation, you could still use GRIT's services. It'd just be a rate you would have to pay. Some things that people don't know about GRITS, so GRITS can take them to, mental health appointments, doctor's appointments. They transfer people all over, even to Louisville, specialists there. But you cannot have an automobile in your name. And a lot of people don't know that, and they automatically think they can get GRITS. If it's an automobile that is not drivable, then they have to have a mechanic sign a statement saying that automobile is not drivable. But if they have one in their name, that's a glitch for them getting GRITS services. Another thing too is that they can't transport. If they have 3 kids and they're going to their doctor's appointment, they can't transport all of their kids, the parent and the 3 kids. Now, if the kids had doctor's appointments, they can. So those are some things that the general public doesn't always know about GRITS. They just think they can hop on there and go. And we deal with that with our clients. Like we try to.
Yeah, and not to keep asking you questions outside of your realm here, but the GRITS transportation, is the GRIT, I know we have a huge, like, Burmese population now. Will they transport folks that maybe are undocumented, or do you have to have?
That I'm not positive.
Okay, I just thought of that. It wasn't even one of my questions until you started.
It's a very good question. I know as far as LIHEAP, trying to think, and I don't think GRITS, like LIHEAP asks for social security cards, and you have to have all that information for LIHEAP. Now GRITS, I don't believe they get social security cards or anything like that. And I know we have undocumented people obviously in our program, but I'm not really positive about that with GRITS. That's a wonderful question.
No problem, no problem. One other thing I'm bringing up, for those that don't know, Audubon area runs the entire Head Start program. So I know most of us are familiar with Head Start, and you think that's its own little entity, but that's actually under Audubon area as well. So they are there for any of your needs with youth that are in that age group or that population. They also have Owensboro Regional Recovery, which is a substance abuse recovery program. So for those that weren't aware of that. And also one thing, the Audubon Area Community Care Clinic, I don't think a lot of people are familiar with these, that it's fairly new. I think it's only been over there a couple of years maybe, but that basically works, again, just to kind of update everybody, on a sliding fee scale, which anyone that falls into below the 200% poverty level, you're on a sliding fee scale. If you're below 200%, absolutely everything you receive in there is free. If you're a little above, it's on a sliding fee scale. So you take your income in and they'll base it, and a lot of times you get like a $10 visit and your medication's paid for. So for our low income families, I mean, Vicki, you can jump in, and I'm just kind of saying what I know. You know more.
It's a wonderful program. It is new to Audubon. I think we're on our 2nd year. I've got the statistics right in front of me. I had it just last year. They saw 573 patients, 457 homeless patients, 17 veterans, and then 10 agricultural worker patients. They have moved locations. They are no longer on East 9th Street. So for those of you who don't know, they're in the old, I think it's called Bridgewater Building.
They're right by Chick-fil-A.
Yes, Chick-fil-A. Yes, everybody knows where Chick-fil-A is, right?
That's why I always say, if you know where Chick-fil-A is, you can find it.
And they're doing COVID testing. Now, I had my COVID test there, so they come out in the parking lot and do COVID testing.
Poor thing. I'm so sorry. I hear the test is first.
And I went on vacation, so I had to have a test when I came back. But,
gotcha.
But yes, it's a wonderful clinic, and they'll address mental health issues as well, addiction. I mean, they're covering a lot of needs for people there. So,
I think I'm correct in saying that you can have, if you have family members that are in a bind and don't know where to go, I'm pretty sure you can walk in. I'm sure they would prefer you call and make an appointment, but I think you can also walk in to those as well.
Yes, it is walk-in clinic. Yes.
Gotcha. All right.
Um,
And to jump back to jump back to FPP, we did have a question. I hadn't read it out to you about the training. What kind of training does your staff receive before they start in as a specialist?
oh, gosh, that's a lot. Well, as far as within our department, our program, when they first come on board, they will see a case from open to close with a seasoned specialist. So they're going out on visits with them. They're seeing all the paperwork, process, the assessment tools, and things like that. They have to have a degree in psychology, social work, a related field like that. We have we do have a couple with the education background, but in order for the state to allow us to hire them, they had to have experience in working with families and children outside of even education. But they've been some of our better employees, so I'm glad they're still letting us take those with education backgrounds. Then after they shadow with another specialist for a minimum a month, it could be more, then when they get their first case, a supervisor, so like on my team, someone gets their first case, I'm going out with them on 50% of the visits, and I'm going to be there for the more pertinent visits. And then we are required to do ongoing professional development training. All of our staff right now are certified in motivational interviewing. For those that may not be familiar with motivational interviewing, it's widely used in the therapy field, and we're not clinical therapists, but it's a tool to use to help people recognize where they're at in life as far as change and change that needs to take place in their life, and how to get them to that place, like motivating them to get to that place, or even recognizing they even need change. We're certified in that. We're certified in trauma-informed care. The NICFAS assessment. Those are the three things that definitely everybody goes through when.
Does the NICFAS require a specific certification?
The NICFAS?
Well? Yes.
Yes, it's through the cabinet. Yes, we do the training through the cabinet, and then they get certified through that way. Yes. Oh, and then also, I'm not talking about our case model we use. I said earlier, home builders model is the new model that the IPS intensive services programs are using, and they will go through a year certification process with that. Our 3-month programs, we use a model called solution case-based model by psychologist Dr. Christensen. I'm a CSBC nerd. I love this case model, absolutely love it. It's very person-centered. That's what I like about it. And I did the home builders model years ago when I was an FPP specialist in the 90s. I've seen both models. They're both good models, but I really like, I see clients change. I feel like change more with the SBC model, and our staff have to be certified in that model as well. And it's about a year process in being certified. It's pretty extensive, but it's well worth it.
Can you tell us again what that was?
It's called solution-based casework model, and it's just a model, and that's where you do a family agreement. You set a family goal with a family. You set individual goals with the family. We do an action plan. So if they say, well, my goal is to address my mental health and have more positive parenting practices, then we do an action plan where we break it down in tasks and steps. And then how we're going to.
I'm sorry, Vicki.
That's okay.
Can anyone get these trainings through NICFAS and that one? Can anyone sign up for them, or is it a certain group?
SBC would be expensive because you have to first be trained by they're from out of state. We fly them in. The supervisors all had to be trained and certified to train others. And then you pay yearly for the case model. So I don't think they would not be open to people being trained in it, but it is expensive. So it's not like just going to a 2-day workshop or something like that. The NICFAS, I'm not sure. That's through the cabinet. It's the cabinet's tool. But as far as if CASA was interested in that, that might be a question to ask someone at the cabinet and see. Do it through their TWIST training. Their EKU training site. So.
Gotcha. All right. I think that was I think that wraps up most of my questions. Is anyone else out there? I hate dominating these. If anyone else has any questions, they can certainly ask now. Anyone? No? Okay, well, again, Vikki provided us prior to this, a PowerPoint and their annual progress report, I believe, which I will send out to all of you guys so that you can have it and look back over it. If you have any further questions, I'm sure you can reach out to myself or Vikki. But again, we can't thank you enough, Vikki, for being with us.
Can I end with one note?
Yes, you may.
I just want to just to tell you how effective the services are, and under the Family First Act, if for those of you who aren't familiar with what's happened under that, some money was reallocated that used to go to foster care because realizing that obviously foster care is needed, we need those programs. I'm a foster parent, adoptive mom. I totally believe in foster care, but realizing that we need more upfront services and programs and prevention to prevent kids from even being disrupted and moved from their home and put into placement or care. So FPP was recognized as one of the top programs to money to be reallocated to us under that. And we were able to hire another supervisor and more staff, and we're able to extend our cases now. But one reason FPP, not just our program, but across the state, was recognized as a program that needed some of the biggest chunk of that money was seeing the outcomes and the results that FPP provides for families. So I'm just going to end with telling you guys our statistics from last year. In the last fiscal year, we served 182 families. This was even during COVID, so our numbers were definitely down during the several months of COVID. There were 390 at-risk children that we served, a total of 469 children in the home, but the 390 is the children that were deemed as possible risk for removal. We closed 182 cases complete, with 98% of those children remaining in the homes. And then we do a 3-month, 6-month, and 12-month follow-up. And last year at our 3-month follow-ups, 97.9% of the children were still in the home, 6-month, 96.4%, and 12 months, 93.2%. And in the history of Audubon FPP, we have some of the highest numbers in the state, but in the history here since like the 80s, we've never been under 85% of the children remaining in the home at 12 months.
Wow.
So it's a very effective program. Now, we do see families sometimes come back into our program, but maybe the children were not removed, but they just saw that they still needed more services or more, issues arose. But so we do have people repeat the program, but well, that's just bragging on the program intervention models.
Yeah, those statistics are phenomenal. Kudos to you, to FPP. We're so happy to have you here. And I'm really thankful that you joined us today and enlightened us a little bit on exactly what you do. Like I said at the beginning of the Zoom, a lot of times we just hear, well, they've placed FPP in the home, but we don't really know as CASA advocates what exactly that entails. So you have certainly educated us today, and I can't thank you enough for your time for doing that. And you've educated us on a lot. I know I mainly threw those certain Audubon programs because I thought they were programs that a lot of our families could use that maybe not everyone was familiar with. So thank you so much for stepping outside of your program.
Well, that attachment I sent it has an overview of all 23 programs Audubon has. So that'll help you guys. And
guys, and I only asked for about maybe 5 or 6. There's 23. So
yeah, there's 23 and 36 counties I think Audubon's in. So that attachment will help. It's our annual report, which is for 2018 because they're working on the next one. But it's our annual report, and then I just have like a little. We've went over most of that, but a little PowerPoint
Yeah,
for
we'll make sure to
FPP.
get that out to everyone. Like I said, we'll send that out to all of our advocates to help them as well. And we can't thank you enough, Vicki, for what you do for
Well,
the
thank
families that
you.
work
Thank you
with.
guys. Is Rosemary still on here?
I think so, but I don't.
And
I
good
see
job,
it.
Rosemary. Rosemary's taken CASA to the next level, and that's amazing. You've done a great work, Rosemary, and your team and staff, and I'm so proud of CASA.
I think she turned her video off, Vicki, because we had to congregate into one room in order to get reception. So I think she's got a bunch of the advocates all together. So they're
Okay.
all watching from her office, I believe. But
good job. And we'll keep trying to find ways to collaborate together.
Yeah, I'm really glad to hear that we can do that. That's awesome. Thank you so much. You have a great rest of the day and week.
You too.
We look
Bye,
forward
everybody.
to working with you.
Thanks for having me. Bye-bye. Bye.